this? It's a pleasure to be here, an honor. Thank you for the invitation. I'm a cardiovascular specialist. I do both coronary and endovascular interventions, almost half-half. And I'd love for this talk to be as practical as possible. I'd love to give you as many pearls for your clinical practice, also the technical world, and I'd love for this to be interactive as much as possible so you can get something out of it. So basically, these are my disclosures. I thought I would kind of divide it up into two main categories, arterial and venous. And within arterial, we'll talk about endovascular therapies and venous endovascular therapies too. So the first part of the talk will be arterial. Interrupt me anytime if you have any questions, please. So just a quick epidemiology. We have almost 15 million Americans living with peripheral arterial disease. Unfortunately, 1 million out of those 15 million gets diagnosed every year for multiple, the reasons are multiple for the lack of diagnosis. And only 50% of those who are diagnosed actually get treated. So we end up with almost 250,000 amputations per year in the United States alone, without having had an angiogram. So that's reality, that's what's happening, that's Medicare data. So obviously one of the reasons why we'd love to show you what we do is so that you see that this saves lives. How do we actually define? Just to give you a little refresher, there used to be a Fontaine classification. We like the Rutherford classification because it's a little bit more specific. As you see, stages 1 to 3 are various degrees of claudication, which is most of the time a sensation of burning, weakness, and severe pain, mostly in the calf and the foot area. Once you are at a level where you're hurting at rest, and this is when you guys see them most of the time, it's rare that they tell you they have claudication because obviously they change their lifestyle based on that. You see them at a stage where they're hurting in the middle of the night, they're waking up, they're extremely symptomatic. And then stage 5 is whenever they start developing skin tissue loss, and stage 6 and when you start seeing gangrene. These are the stages that we call critical limb ischemia or chronic limb-threatening ischemia. CLI or CLTI is kind of the word in our world. Obviously, physical exam, you're familiar with that, but I'd love to kind of share my practical experience of our patients are complex. They have 10 medical problems, and often enough they have both venous and arterial disease. One of the clinical signs in the office that allows me to kind of isolate the arterial insufficiency component is I raise their legs as I'm asking them questions while they're laying down for about 30 seconds, and then after 30 seconds I drop their leg down and I kind of watch their foot. This is the kind of sign, the dependent Truber that we studied in medical school. And that's something that kind of differentiates arterial insufficiency over other etiologies. And you'll see that dynamic change immediately. They count on gravity to get blood flow to their feet. The pressure in their toe is 5 millimeters of mercury. So gravity by itself, that's why they wake up in the middle of the night. And kind of walking a few steps, the walking itself is not actually relieving the ischemia. It's the gravity that's relieving the ischemia. So when they tell you it gets better when I walk, it's just the fact that they stepped out of bed. And this is the stage 6 that I told you about. This is typical arterial insufficiency signs. You can see the very well demarcated skin margins. You see the dry base. You see it's extremely tender. And the location is most of the time distal relative to venous ulcers, which I will show you in other slides. We think about fixing arteries in the leg based on what we call the angiosome concept. That comes from plastic surgery, from the burn literature, where a plastic surgeon takes a flap from one vascular territory and applies it to another. So they divided up the foot and the leg into different zones perfused by different arteries, namely anterior tibial, posterior tibial, and perineal. And every time we think ulcers, we think this way. There's not much blood flow to one of those angiosomes, and my job is to get arterial outflow directly into the wound. So a complex slide, but what I would like you to take from it is mostly, as you see up here, ABIs are the central core of screening and diagnosis. Of course, they have limitations, and we'll talk about that, but this is how you start with these patients, and most of you have ABIs in your office. If the ABI is normal and you're still suspecting PAD, have them do kind of 5-minute walking around the office and repeat the ABI. You'll see how much they compensate. Our bodies are so resilient. There are a million other arterial channels that form at rest, and you'll be surprised a 0.3 drop in ABI is actually significant. So basically, we categorize them into 3 categories. Either the abnormal ABI, and those are going to get either exercise ABI, get treated, and if that doesn't work, they'll go to CT, duplex, etc. The other category are the extremely calcified patients where the ABI is 1.7. And obviously, we know it's not 1.7. That artery you cannot compress. So in that case, we go to something called TBI, which is the toe brachial index, where we place a cuff around the big toe, and we actually, as calcified as the artery is right there, you can compress it. So that little cuff, when you compress it and you get Doppler signals, it's kind of a way to diagnose arterial insufficiency. And if it's less than 0.7, it's abnormal. Basically, going through the algorithm also in the range of whenever it's less than 0.9, then we go for an exercise ABI and we treat them. And if that doesn't work, obviously we go in the invasive route, either endovascular or surgical, and we get imaging studies. One of the imaging studies are duplex ultrasound, which is both anatomical and functional, but also there's CTA, MRA, and finally invasive angiography. And the decision about what to do depends on every patient. So the critical limb ischemia, when they get to this stage 4 to 6, as you see here, obviously ABI is sometimes very disappointing, and we use other alternative methods besides TBI called transcutaneous PO2, which is a transcutaneous oxygen pressure. It's a form of oxygen plethysmography that allows us to detect ischemia in the toes, and skin perfusion pressure. Those are tests that you can order from the office, and some imaging centers can do that. So the ankle brachial index is done just going back to the basics. It's basically taking the highest of the blood pressures in the foot, whether it's the dorsalis pedis or the posterior tibial, and dividing this up by the highest of the brachial blood pressure. So both arm blood pressures, you take the highest of those because we want to isolate the subclavian stenosis. Those are vasculopaths that have also occlusions in the upper arms. And you take that in the denominator, and you take the highest of the two. So if the dorsalis pedis pressure is 70 and the posterior tibial pressure is 0, and you have an ulcer on the heel where the posterior tibial provides blood flow, your ABI is going to be 0.7. If the upper arm pressure is 100, 70 over 100, 0.7, it's a mild arterial insufficiency. While this occlusion right here, 100% occlusion with no flow, is actually blocking the flow. So don't stop at ABI. Every time you suspect and your clinical suspicion tells you we need to proceed more than that, kind of get further testing or further investigations. So what's the reason of falsely normal resting ABI? Of course, we mentioned non-compressible vessels, meaning the perfusion in this vessel is trickling, but the vessel is so thick and so calcified, you cannot compress it. So your ABI is going to be falsely elevated. Another reason is significant collaterals, especially in the aortoiliac occlusions. You can't even imagine how many internal iliac collaterals circulate from the rectal uterine area back to the inferior epigastric, down to the thigh. There are a million ways for the blood to get there at rest, but if you exercise them, you'll see that this drops pretty quickly. The one vessel disease, infrapopliteal disease occlusion, like I told you, when you have one occlusion and one vessel that's open, but still we have an ulcer, that's a situation where you have a normal ABI. Aortoiliac disease, a lot of collaterals, and whenever you have bilateral upper extremity occlusions, so those are, those smoking patients that have smoking history is more than 50 years. All their arteries are occluded, so your denominator, the subclavian artery pressure, is 50 or 60, and then your toe pressure is 50 or 60, so is 30 or 40. So that ratio is falsely elevated and tells you, okay, they don't have PAD, but they actually do. So what other methods? The TBI, transcutaneous PO2, or skin perfusion pressure are the tests to kind of order if your suspicion is high. Is there a correlation between ABI and TBI? Not much, actually. You can see the points are all over the place. And for that reason, that strengthens the statement that about the clinical suspicion. If your clinical suspicion is high, you can see that TBI can be abnormal in this wide range of ABI. So order that. Now, the patient population that you're seeing way more often lately than before is the type 2 diabetics that are so brittle, so advanced that it only affects the vessels below the knee. So you get all kinds of testing, but most of the time you have 3 vessel occlusions below the knee. The ABI gives you a falsely normal. Then you go for a duplex ultrasound, and it's very tech dependent. The tech can't really follow all the line of the arteries. Then you go for a CTA, and then the calcium artifact is very difficult to read through when you have such calcified arteries. And then if you go for an MRA, there's suboptimal opacification, especially in the setting of heart failure, where the gadolinium doesn't even reach the feet. So this patient population ends up with no abnormal test, but you have an ulcer in front of you, and you can swear this is PAD. What do? Then you go for an invasive angiography. This is where the clinical suspicion you can see here, this is a popliteal artery. You're supposed to see a lot of blood vessels below the knee here. The blood flow stops here. And then the operator goes through that with a catheter all the way down to the dorsalis pedis and injects dye into that artery. You can see there's almost nothing in there, and their ABI is normal. Same thing into the plantar. So long story short, clinical suspicion trumps all of that. So how do we fix that? That's kind of the fun stuff for us. Basically, the most traditional way is balloon angioplasty, which is obviously taken from the coronary experience and literature. But we have gone a long way in terms of balloon technology. There are all kinds of fancy balloons now on the market, the pillowed balloons that minimize the risk of dissections. There are scoring balloons that have wires spiraling around it that allow us to inflate that at a very low inflation pressure and induce much less barotrauma to the vessel and have much longer term outcomes than a balloon angioplasty that we inflate to 20 atmospheres. We put blades on balloons that we call those cutting balloons. There is a massive, massive number of drug-coated balloons where we put paclitaxel, a chemotherapy drug, on the balloon to minimize restenosis. And that has been revolutionary in our world to minimize the numbers of stents that we have to place, because placing paclitaxel in the wall of the artery after we inflate the balloon and cause injury minimizes scar tissue formation and restenosis and improves clinical outcomes. There are multiple techniques that we have taken from the coronary literature and experience where we go in from both sides with 1 balloon, 2 balloons, different wires. So basically, it's very, very operator dependent, and there are 10 ways to fix an artery. So just know that there are a lot of experience in that, and this is developing quite actively. You can see here in this case where we come in from the foot through the dorsalis pedis artery, we stick that, we place an IV through which we advance a balloon. We meet in both subintimal spaces. We inflate both balloons to kind of break that tissue, and we pass a wire through. Once we pass a wire through, we can treat it and do all kinds of atherectomy interventions. So this is a video showing what is orbital atherectomy. We use that in the heart and in the legs. This is both FDA approved for both. As you see, this crown right here has pieces of diamonds on it, and the property of diamond, whenever we rotate it at 90,000 RPM, it actually hits calcium but does not hit soft tissue. So if you put it on your finger, it doesn't actually do anything, but if you put it on your nail, it punches a hole in your nail. So it has the differential cutting properties that allow us to not injure the true vessel, but to actually treat calcium. And you would ask me those little pieces of the particles that come out of this atherectomy, where is it going? They're so small, they're smaller than red blood cells, that the endothelial system, reticular endothelial system, kind of gets rid of them through the macrophages and the immune system. So it doesn't cause distal embolization as you would think. And of course, if we're dealing with a massive kind of popcorn lesion down there, it can. But if the operator is very meticulous, it's very, very minimal distal embolization. It opens up. So what does that do? It allows us, when we place a balloon through that blockage right here, we place a balloon, you go up to 24 atmospheres, and it just does not yield. You have this napkin ring balloon. So the wall is super calcified. It needs to be modified. We use tools like that to basically sand the calcium and make that vessel much more flexible so it responds to the balloon angioplasty. So this is not a standalone therapy. It's add-on therapy to balloon angioplasty. This is another type of technology, laser. A laser, as you can imagine, it has photoablative properties, meaning it burns tissue, and it burns in a front cutting manner. And that tissue that's vaporized literally gets out of the way, and it also treats thrombus. So whenever we have thrombus plus plaque, laser is one of the best techniques for it because it vaporizes both clot and calcium. If we put the previous orbital atherectomy device through clot, it showers clot like crazy, and you can actually end up with amputation just from using it in a clot. So there are different technologies that are applied in different kind of patient population. Directional atherectomy is another form, a third form of atherectomy, which is obviously endovascular. It's all endovascular. You can see that blade here shaving the plaque in a physical manner, literally collecting that into a reservoir. And we pull back, we turn the motor, and that blade literally shaves that plaque in 4 different quadrants. And it's very much, we can adapt it to the patient's anatomy. We can shave here versus here, et cetera. So it's like a surgical, endosurgical technique. And all of that is done through a tiny little IV, either from the foot or from the groin. The fourth different type of atherectomy is excisional atherectomy, which is an Archimedes screw that dissects bluntly through the plaque and also treats thrombus. And as you can imagine, that tissue goes back into a reservoir in the back of the catheter, and we get all that junk out. You'll see it literally, it's real. Now, when atherectomy and balloon angioplasty don't work, we use drug-coated balloon. If that doesn't work, we can put scaffolds in the artery. And we have had a tremendous experience and outcomes with stents. There are different kinds of stents. What you see here is a self-expanding stent. That's what allows us to place those in the thigh. When someone's flexing, extending, moving around, that moves with the tissue and is very flexible. It's made out of a metal called nitinol, which retains its own form. So every time you compress it, it goes back to its shape. It can be uncovered versus covered. When we have grafts or aneurysms, we want to cover them. It's covered with a PTFE layer. There are balloon expandable stents. Those are stents that self-deploy. Those stents are deployed when the balloon is expanded and stay at that kind of deployment shape. There are also uncovered and covered, and we choose the ones that, and obviously different territories and the different vascular systems have different studies. Now, below the knee, our problem with below the knee is the stents used to fracture. So we used to place coronary stents off-label because there's nothing else on the market in the tibial arteries, and they used to come back with, as you can imagine, the muscle compartments in the calf are so strong, they crush those arteries. And when stents get crushed, then endothelial injury happens, then you induce thrombosis, then the vessel reoccludes, and you're back to square zero. So innovative spirit came about, and small, tiny, little stents that are barely, the length of that stent is barely 1 centimeter. They're self-expanding. We can deploy them in a kind of a very custom fashion in different parts of the vessel without lining up the vessel with all metal. So those seem to be more adaptable to the forces of the muscles trying to crush them, and we can put them even below the ankle into the dorsalis pedis and keep that vessel open if it keeps reoccluding with balloon angioplasty. These are real life cases that Dr. McCurry and I had taken care of when I used to practice in Cleveland. This case would have gone straight to amputation 10 years ago. You can see, I mean, this is stage 6. There's absolutely no flow. And with endovascular therapy, you can see that this definitely works. Now, you take a patient, instead of an above-the-knee amputation, now they're going to have a great toe amputation. You change their life. They're able to walk. All their comorbidities remain well controlled. Having a patient who walks changes everything. And that's why saving limbs saves lives. And this is the same patient before and after. You can see right after the procedure, we transformed a massive operation to just a toe amputation and wound care. This is a case where it was not doable. That case that we did was not doable from the groin. That case highlights the use of alternative access sites. Now we go from the wrist, like we go to the heart, with longer catheters down to the leg. And whenever we have occluded vessels in the groin that we cannot stick, we go from the wrist on both sides and we get equipment down, or we go from the foot in a retrograde fashion, like this case that we had published. Those are the alternative access sites. Sometimes we go from the axillary artery, we stick that if we need large bore equipment and large artery. When we can get by with small arteries, there's now 200 centimeter catheters that we can go from the wrist all the way down and take care of the tibial arteries from the radial. And the advantage of radial is patients go home in 2 hours. They have a little Band-Aid on their wrist. They had a massive atherectomy instead of a 1-month hospital stay after surgical bypass, etc. So it has decreased the morbidity tremendously and allowed us to be as minimally invasive. And that's how you see all these patients getting treated in the outpatient centers instead of staying at the hospital. This is an article we wrote on the different alternative access sites that we can use. You can see here we can go from the back of the thumb, like we go up to the heart. We call that the anatomical snuff box, and down from the leg. While patients who cannot lay flat, we have them sit up during the procedure, and we go from their feet with these types of access site in a retrograde fashion and open up the blockage and come out and just put a semi-Band-Aid on it. It's very convenient. Obviously, it's very meticulous. Those vessels can be injured by operators who keep sticking them, don't get access. You can actually injure that and induce ischemia. So it has to be done in trained hands and with some experience. This is the kind of access site. This is almost like a 16-gauge IV, basically. Through that 16-gauge IV, we advance all the atherectomy devices that I just showed you through that, and we just put a little kind of inflatable band around it for an hour, and then in 2 hours they walk and they go home. So the morbidity of those procedures has been transformed lately. This is an actual real-life case where anatomy here, this is the popliteal artery, that's the knee joint. That's the anterior tibial artery coming down. You can see a severe stenosis here and then an occlusion, 100% occlusion. There's no flow. There's a small little collateral here. Then you have the tibioperineal trunk, perineal artery, 100% occlusion. There's no flow here. Posterior tibial artery, 100% occlusion. So basically triple vessel occlusion, infrapopliteal occlusion, non-healing ulcer at the medial aspect of the first toe, which is a combined angiosome of both anterior tibial and posterior tibial sometimes. And after intervention, you can see here that we used orbital atherectomy, that spinning device. You can see how it cleans that out really nicely and provides blood flow. Within 3 weeks, you can see how that tissue just regenerates. And those patients don't even lose their toes if we catch them at the right time. So in the traditional vascular sense, it used to be just open up the blockages above the knee. The vessels below the knee are very, very hard to work on. They're very labor intensive. It takes about 2 hours to open up a vessel. Not everybody wants to invest that time. It takes a lot of energy. It takes dedicated staff. A lot of vascular specialists used to just open up the femoral and popliteal and let the collaterals kind of take care of that. For some of you who do wound care, you've seen that. It doesn't work most of the time. You definitely need to open up the blood flow directly to the wound to get regeneration of tissue. So that's where the revolution happened in the last 10 years. We even go to stick the foot. Whenever we cannot find arteries in the dorsum of the foot, we go through the thick skin of the bottom of the foot and stick a catheter in there and do the intervention through it. And of course, it's very meticulous and you can damage the vessel, but those patients are heading towards amputation otherwise. They almost have nothing to lose. If those vessels are almost atretic, we cannot access them, we go from one circulation to another. So let's say we're going down the anterior tibial and there's no flow in the posterior tibial territory. We go through a collateral and we advance coronary equipment that we use in the heart to go backwards through the vessel without sticking a vessel in the foot. There are multiple ways to connect the dots, the anterior circulation and the posterior circulation, and we go through those tiny little collaterals, and we use mostly coronary equipment to get there. This is an example here. What you see here anatomy-wise is this is the anterior circulation, the anterior tibial dorsalis pedis. This is the posterior tibial, main plantar, medial plantar, lateral plantar. And so you can see a wire that we're floating here from the dorsalis pedis artery through the pedal arch, retrograde, into the lateral plantar, back into the posterior tibial to be open, to open that up because we could not get alternative access. So the community has become creative in finding alternative ways. Now, one message I also like to get across is the CO2 in renal patients. Most of those have renal insufficiency. As you know, diabetic, creatinine 2.0 and above, and now they need an angiogram. You say to yourself, okay, now we're going to induce renal insufficiency, risk benefit. It's easy now. There's CO2 gas. CO2 gas doesn't cause any renal insufficiency. They can have a creatinine of 3.5. And you take them to the lab, and you can see the imaging that you see right here. Very clear with advanced imaging modalities. We're literally spinning a wire through an occlusion below the knee here, and we have used 0 cc's of dye to fix that leg, and the patients go home without the risk of renal insufficiency on the same day. So there are alternatives. Obviously, CO2, the downsides of CO2 in bad COPD patients, you raise their CO2 level. So you have to watch how much CO2 you're giving. 2, it hurts a lot, so we do it under general anesthesia. CO2, when we inject it, for a few seconds, we're inducing ischemia. So there's not much, oxygen going on. So patients hurt a lot. We learned very quickly, we sedate them, and we work on them while they're sedated. Otherwise, it doesn't work. They'll move all over the place. So you ask yourself, okay, this is very nice, and you're opening up but why? This is why. We have a major mortality benefit intervening on those vessels. Patients with critical limb ischemia have a mortality close to some of the esophageal and pancreatic cancers. You can see that in 1 year, almost 20% of them are dead. In 10 years, only 10% are still alive. Those are very sick patient population. It's not necessarily the amputation, the limb ischemia that's killing them. It's all the other comorbidities. But when you keep them walking and you allow them to continue to walk, this is where you can make a big difference. This is Medicare data before 2018. You can see here the patients with rest pain versus ulceration versus gangrene. It directly impacts their mortality. That's why whenever you see an ulcer on the foot, that's a sign that things are not going to go well unless you help them. And you can see the difference here. Above the knee amputation, look at the mortality curve. This is Medicare data, real world. And then with surgical or endovascular revascularization, which is equivalent here, you can see how much mortality you save in Medicare patients. So this saves lives for sure. Same kind of idea, look at the above the knee amputation mortality. It's almost like esophageal cancer or pancreatic cancer. Almost half of them die within 1 year when they have their leg amputated above the knee. It's just a death kind of sentence for them. So all of this is good, but multidisciplinary care with wound care, podiatry, and if some of you do wound care and care for them, this is where I can open up all the vessels, but if wound care is not appropriate, all of that fails. Infectious disease, antibiotics, good blood sugar control, etc. All the medical management of the inflammatory risk factors, that's what's going to help them. Opening up the vessel, it closes up in 2 days if their blood sugar is 400. That's not going to work. So that's where this is kind of, it takes a village to help these patients, and we count on you a lot. So going from arterial to venous disease, I'm going to try to be quick on this one since it's so prevalent. Venous disease pathophysiology, as you know, most of the venous disease is related to valvular insufficiency, the valves don't work, or an obstruction in the outflow, in the iliac vein outflow, or a combination of both. Someone could have had a DVT after orthopedic surgery that closed up the iliac vein, and now all the valves are refluxing and causing that. History-wise, we count on the acronym HASTY, heaviness, achiness, swelling, throbbing, and itching, which is extremely prevalent in our patient population. A quick reminder and physical exam of the stages of venous insufficiency. Stage 1 is when we see telangiectasias and prominent reticular veins. Stage 2 is when you start seeing varicose veins without swelling. Stage 3 is whenever you start seeing swelling, obviously related to the extravasation of plasma into the soft tissues. Stage 4 is when you start seeing skin color changes, lipodermatosclerosis, but you don't have ulcerations yet. But you're seeing all these hemosiderin residues from the hemoglobin breakup. And stage 5 is when someone had an ulceration in the past and it has healed. Like in this case, it's usually sometimes painful. Stage 6 is active ulceration. All of us have seen this in clinical practice. The way it differentiates from the arterial is the location. You can see it's mostly located on the medial aspect of the ankle. The beefy red, very congested background, the not so regular borders, and it's less painful than arterial and tolerated a little bit longer. How do we diagnose that? We stand up patients. So whoever had a duplex ultrasound at hospital X, no DVT, that's not the test for them. We're talking about someone standing and a technologist spending 15 minutes trying to diagnose reflux on those. What they do is they squeeze the calf, and you can see the flow in this femoral vein go in this direction, and then they record the reflux, the flow in the opposite direction. That's how reflux is diagnosed, and after treatment, how the reflux is gone. So it's a specialized ultrasound that needs to diagnose that. I thought I would give you a quick kind of run through what we do in the deep venous world. Invasive therapy in the vein space is divided into deep venous versus superficial venous. Superficial venous is what you see most of the time in the outpatient world, ablation of the saphenous vein grafts and sclerotherapy, mostly for cosmetic reasons, kind of a sclerosant agent injected into the reticular veins. A lot of people are getting into that. Deep veins are divided into clot versus no clot. That's how we divide them. So non-thrombotic versus thrombotic. Let's go through that. The non-thrombotic is the May-Thurner syndrome that we studied in medical school, which is way more prevalent than we think. This is an aorta, the iliac artery bifurcation. This is the inferior vena cava. This is the common iliac artery on the right crossing the left common iliac vein. That crisscross right here, that's why a lot of times you see swelling in a lot of patients in the left leg way more than the right leg, because of that. 20 to 25% of people have this anatomy. That doesn't mean that 25% of people need stents, but almost 10% of those 25% need some help with this stent right here if conservative, non-invasive therapies don't work. There are a lot of dedicated stents now that we can place in the iliac veins, and we have specific interventional criteria. Now, this was the non-thrombotic. What about clots? Thrombotic. How do we fix clot without surgery? In two ways. Either thrombolysis. All of you have probably seen patients who lay in the ICU for 24 hours with a catheter in their iliac vein, infusing thrombolytic therapy. That's catheter-related directed thrombolysis. And then ultrasound facilitated is new technology which is added to the catheter-directed thrombolysis that I will explain in the next few slides. Thrombectomy is physically removing clot from the vein, and there are three different kinds: aspiration, rheolytic, and coring. I'm going to show you quick videos of that. Catheter-directed thrombolysis is the most traditional way of doing that. As you can see here, a catheter spraying thrombolytic through the clot, and that thrombolytic would work on breaking the fibrin bonds between the red blood cells and getting the vein open. It doesn't work most of the time. That's why new technologies have evolved, and you can see new catheters that have more contact with the clot. You can see that kind of shape where we're infusing throughout all the surface of the clot in order to be able to get this dissolved. That's called the Bashir catheter. Then you have the ultrasound-facilitated thrombolysis. What that means is the catheter not only infuses thrombolytics, but also has ultrasound emitters that send sonic energy, which is basically acoustic energy, to break up that clot physically by shaking it. And the synergistic activity of the thrombolytic with the mechanical disruption by the ultrasound waves makes it way more effective. And I'll show you a real-world example of that. So it has been way more effective than just infusing a clot. This is a real-world case. All of you have seen massive DVTs. You put them on anticoagulation. Almost 50% of them still have post-thrombotic syndrome. 50%, of course, get better with just medical therapy, but the ones who don't get better, this is a patient who worked at Walmart, comes in 3 weeks into her extensive iliofemoral DVT on warfarin. This is a case 5 years ago, back days of warfarin, and therapeutic INR just cannot walk, cannot get back to work. So let me show you the angiograms. Pardon me. So this is the venogram. Would you mind clicking on that video on the left, please? So this is a venogram. We have a sheath in the popliteal on the left one. Yep. So this is the contralateral iliac venography. But if you can click on this one, please. This is a sheath in the popliteal vein. We have patients laying on their belly. They're under general anesthesia. We go through the popliteal vein and we inject dye. Do you mind clicking on that video, please? For some reason, it's not. This one, please. It's not playing? Okay. So basically, this vein here is completely occluded. There's no flow going up north. What we used is something called rheolytic thrombectomy, which is basically a catheter that's placed through that clot, and there's a high volume jet of normal saline within the catheter that's going through it, and the vacuum that it generates will aspirate clot. It's the vacuum. We use that super fast flow through the catheter to allow vacuum to aspirate clot. And this has been very effective on that patient. So you can see now the entire vein is open. That's kind of 3 hours later, but a lot of work has been put into that with the IVC filter and all of that. And this lady is a real world, obviously. You can see the dramatic changes. They go back to work, and those are 35, 40-year-old patients. They're not elderly. They have a life ahead of them, and you can see the disability that post-thrombotic pathology causes. These are different kind of thrombectomy devices where you can see that catheter, how it cleans out that clot on the bench. This is how effective it is in real life. Of course, we have to catch it within a few weeks to a month. If it's more than 3 to 6 months old, it becomes collagen. It's hard to aspirate, and we have other ways, which is this coring thrombectomy. This is a device that works on clot that's more than 6 months old. It's introduced through the popliteal vein and through a very ingenious mechanism where this basket, you can see the patient is laying on their belly. We go through the popliteal vein, and we place that catheter into the vein, large catheter, and obviously it has to be done with very experienced hands because we can induce nerve trauma, etc., by doing that. And you can see that basket that gets expanded into the vascular space, and we literally pull that back into that basket. And the kind of clot that comes out is this kind of clot. This is chronic, collagenous clot that is unbelievably effective, and those veins open up really quickly. And with that, I end my talk, and thank you very much.